All righty. Good afternoon, everyone. Thank you so much for joining us. We have one of our alumna, very, very well-known alumna, Dr. Babak Kateb, who has assembled an amazing group of experts in the medical and science field. And he's joined us today with his colleagues to talk about vaccinations to us. And we are recording this, so it will be available later on for you to see, and we'll make sure we get it out on all of our social media to you as well. If you have questions, you'll be able to put questions in the Q&A, and we are joined by one of our students, Natalia Diaz, who will be fielding the questions to Dr. Kateb, who will fit them to the panel. It's to you, Dr. Kateb. Again, thank you so much for all of you coming this afternoon. We greatly appreciate it.
Thank you very much, Dr. Gallagher, and I also thank my colleagues on the panel. I welcome the colleagues and friends and students on this call, and starts this kind of discussion about what are the advances in the COVID-19 and which vaccine you should take and why. So let me just very quickly kind of introduce our panels. So we are delighted to have Dr. Mehran Khorsandi. He's a professor of interventional radiology and cardiology at the Cedars-Sinai Medical Center. We have Dr. Eliashiv. She's a professor of neurology at UCLA, David Geffen School of Medicine. And Dr. Yamamoto is joining from, who's a cancer scientist from USC-Norris Cancer Comprehensive Cancer Center at Keck School of Medicine. And Dr. Ashraf Elsayegh, who is a pulmonologist, is a professor of pulmonology, pulmonary medicine at Cedars-Sinai. And also we have Professor Christine Foundation. We are also joined by Dr. Jason Cormier, who is a neurosurgeon and the 19th president of Society for Brain Mapping and Therapeutics. So Jason is almost done with his operation and is going to join us soon, but currently just wrapping up his hospital activities. So today's learning objectives are focused on three things. Of course, introducing the panel and the organizations involved. Second, I'm going to talk about, or we are going to talk about COVID-19 signs and symptoms. And symptoms, including ARDS, cytokine storm, acute hypercoagulable state, sepsis, encephalitis, autonomic dysfunction and dysautonomia, and brain post-COVID-19 physical and mental issues, and discuss vaccination, its efficacy, and why we should take it, or does it matter which one? So this town hall is organized or co-organized by Society for Brain Mapping and Therapeutics and Brain Mapping Foundation. Our mission is focused on improving the diagnosis, treatment, and rehabilitation of patients afflicted with neurological disorders. And our approach is multidisciplinary. So we basically partner with government agencies, patient advocacy groups, educational institutions like LACC, private sectors, as well as philanthropic organizations. So we have our upcoming World Congress for Brain Mapping coming up. I'm sure that you will hear from Dr. Gallagher later on. It's in July 8th through 11th. We hope it's will be held at the LA Convention Center in person and virtually. So this is our past conventions in the last 19 years, and the LA mayor has been gracious to recognize us and support our activity. We're also very active on the many initiatives, including President Obama's BRAIN initiative, currently working with Biden administration on the BRAIN Technology Park initiative. We have been engaging international partners through the UN, started the BRAIN initiative in Australia and Canada, worked directly with the Congressional Neuroscience Caucus, both on Republicans and Democrats, and the Office of Science Technology Policy, worked with pioneers like Stephen Hawking, which we awarded him to advance technology, and worked with NASA to bring technologies from space into medicine. So, what are the conversations that we need to have here? What are the costs of neurological disorders to the world economy? But as you can see, the economic impact of the COVID-19 has been staggering in trillions. And some estimates are that the cost of neuropsychiatric disorders to the world economy by 2035 is more than $14 trillion. So our Neuroscience 20, which is a global initiative partnership with the G20 summit countries, focused on reducing that cost, increasing efficiency, educating public, and fast-tracking therapeutics. In that regard, we are partnering with LA City College. We are establishing a brain technology park, and we hope that you will hear more about this very soon. And we have also published, landmark textbooks and papers. This is a textbook of Nano-Neurosurgery, which is the inaugural textbook. I signed and gave it to President Obama, and that's his thank letter. But this team right here published a landmark paper on COVID-19, which was the most comprehensive review on the subject, as well as we published an MMR vaccination opinion piece. So the COVID-19 vaccine has been enveloped by a nanoparticle. As you may know, it's an mRNA vaccine, and mRNA cannot be injected directly to patients. So it has to be enveloped in nano platforms, which in this picture you will see if the size of a human is 1, this size of nano platforms are 10 to the minus 9. So as small or smaller than viruses. So basically there are 2 definitions on this slide. One is what do we talk about when we're talking about brain mapping? We're looking at the brain imaging all the way to the nanoscale. And the second definition is what is nanomedicine, and that's application of nanotechnology in medicine. So with that, I will stop and basically go back to our distinguished panel and ask from Dr. Mehran Khorsandi to give his thought about COVID-19. Of course, collectively, we have seen thousands of patients, and you are actually, this entire group helped my mother to save my mother. But I wanted to get some thoughts from you, from your standpoint at Cedars-Sinai about COVID-19 and progress made. You're on the mute.
Thank you, Babak. Can you guys hear me?
Yes.
I think the virus caught the world medical community by surprise, obviously. There were precedences with other SARS viruses, but this particular one got out of the bag and could not be contained, as you know. And over the last year, we've tried to define all the clinical sequelae of how it presents. And it can practically affect any organ in the body, and it has different presentations in different people. By far, most people have flu-like symptoms and get over it. But a small percentage of people do suffer late-term sequelae. Unfortunately, it's a very small number of people. And as you know, it affects the older people much worse. At Cedars, we were no exemption. We were exposed to it like the rest of the world. We were lucky in that early on in the exposure last March, the volumes with the first wave, if you will, were not that high. Although it was high, we did not get overwhelmed like some of the other parts of the world and some of the other parts of the United States, like New York got. And actually, the numbers ebbed in Los Angeles. And around Thanksgiving and after that, it surged again, and it surged dramatically to the point that it was much higher than the first surge. However, at that point, about 6 or 7 months had passed. We had prepared, the country had prepared, we knew a couple of specific treatments in terms of the monoclonal antibodies. Somebody had participated in the research there. We knew it was approved. The remdesivir was approved. So we had a few more tricks up our sleeve. We also knew how to better clinically manage the patients. We had anticipated, we had a lot more beds and the personnel and the whole system to go through it. So although our numbers got to be quite significant, we were never overwhelmed at Cedars. We were in a controlled fashion, even though the numbers, let's say about 2.5, 3 months ago, were probably, without exaggeration, 20 times of what we have now. And here we are. For the time being, we feel like we have a handle on it and we're in control. Although the whole world community would like to be able to identify the subset of patients that get so sick that progress to requiring mechanical support and are the group that actually ends up succumbing to the hyperimmune reaction of COVID, if you will. But we do much better now. Our mortality rates are much lower, although they're not zero, unfortunately. And here we are. And unfortunately, there's been multiple vaccines that have been developed now. I think the US medical community started getting vaccinated with the Pfizer vaccine in December. And shortly on the heels of that, the Moderna vaccine came around. And the last couple of weeks, the Johnson & Johnson vaccine has been approved also. So there's been, as much as there was an anticipation before and there were huge doses present, after approval, there's been an even further ramping up of the production. And for now, we seem to be with schedule or perhaps slightly ahead of schedule in terms of vaccinations. And hopefully that would also hugely have an impact on the number of people who will present with COVID-19. There was some very positive data from CDC about a week ago about the efficacy of Pfizer vaccine as well as the Moderna vaccine on actually getting the infection, not just the significant sequela of the infection. So that's kind of where we are today.
Excellent, Professor. Among those symptoms that I listed in the slides, we talk about, let me share this slide here. We talk about, we talk about acute hypercoagulable state. So, in your opinion, of course, you are a cardiologist and interventional cardiologist. In your opinion, I wanted to get some more input about this. And do you see this across the board in all patients and some of the patients? How do you treat them, and what your recommendations are?
Probably everybody gets to some degree of hypercoagulability. I'm not sure. Fortunately, not all of them get to the pathologic level. Among the things that we learned early on is the fact that people clot easier, which we call hypercoagulable, and the clot usually would happen in their legs and go to their hearts and go to their lungs and cause all sorts of trouble. So very early on, the world community understood that we need to anticoagulate people, even blood thinners, if you will. We unfortunately have seen the excess coagulability in the coronaries, in the heart also, in that there is a very, very small subset of patients who actually have an infarction, have a heart attack, which we believe is directly attributed to the hypercoagulability of COVID-19 infections. So it is routine for us to anticoagulate everybody. And the guys who got sick enough to get in the hospital remain anticoagulated for several weeks after they leave the hospital. So I'm not sure if I
for your
lost you
input.
guys.
Dr. Elsayegh, good afternoon. Dr. Elsayegh, your thought about pulmonary issues of these patients. Of course, we have all heard about ARDS, and I wanted to take your, opinion about what do you think of COVID-19? Is this a respiratory disease? It seems to be much more complex. What's your thought?
So, thank you for having me today. I am a lung specialist, and you're right. So COVID-19, unfortunately, is a multi-organ disease. The virus affects multiple organs in the body, the heart, the brain, the lungs, the coagulable state, as Dr. Khorsandi mentioned, meaning that the patients can form blood clots very easily, and some of them have life-threatening blood clots. However, from my standpoint, of course, the biggest issue, the biggest problem that patients can die from in the hospital is the lung involvement with this virus. And what ends up happening is multiple issues involving the lung. The first is, as you mentioned, ARDS. And what that is an inflammatory response. The lungs become inflamed, and they have what appears to be infiltrates bilaterally. And it overwhelms the lungs, and the patients are not able to oxygenate, unfortunately. The problem is when they reach that state, it takes time for the lungs to heal. And trying to maintain the oxygen level long enough while the lungs heal is sometimes very difficult. So that's issue one. Issue two is you can form a viral pneumonia, meaning you have an infection in the lung with the virus, and that again is also very difficult to treat. From the beginning of when this infection started to now, as Dr. Khorsandi mentioned, we have multiple new treatment options, some of which are antivirals, such as remdesivir, and those have helped and have made it a little bit easier to treat these patients. In addition to that, a lot of these patients, when they become infected with this virus, have what's called a superimposed bacterial infection. When people think of pneumonia, most people, when someone, the normal lay person out there thinks of the pneumonia, they think of what's known as a bacterial infection. It's not a virus, it's a bacteria, which in some people is also difficult to treat. So the problem is the patients with COVID infection can also have a superimposed bacterial pneumonia. So now we have to treat them with antibiotics in addition to treating them with antiviral therapy. And finally, Dr. Khorsandi already talked about this, which is the hypercoagulable state. The problem with hypercoagulable state is patients will form blood clots throughout the body. The most likely place to form blood clots is usually in the legs, and that can break off. Some of the clot can break off and go into the lung. When that happens, you prohibit blood flow to that part of the lung that the clot has traveled to. This obviously kills off some of the lung, but also it makes it very difficult for the patients to breathe. This is a whole different problem which we have to treat. So the best part is always to, or the best action is always to prevent the blood clots with anticoagulation medications, which is medicines to keep your blood thin and to prevent the blood clots from forming to begin with. So as you can tell, although it affects many organs, it seems that it hits the lungs the hardest for the patients that are very sick. And most deaths occur because of lung involvement, unfortunately. So it becomes very crucial to treat these patients aggressively and as early as possible.
Excellent. Is remdesivir still in play?
Oh, absolutely. Yes,
or
remdesivir.
treatment?
If remdesivir is FDA approved, it's been shown to have a more significant effect in patients that are more severely ill. However, it does have, although a lesser improvement effect, it still does have an improvement effect in patients that with minor involvement. But it is FDA approved and it is very widely used right now.
Excellent, excellent. All right, great. So, Dr. Eliashiv, you are at UCLA and you have seen a lot of cases. I would like to get your opinion about the neurological aspects and impacts of COVID-19. Any thoughts from you? And of course, we welcome you to this
Yeah.
conference.
So I think that what's very important to note is that COVID-19 is a multi-system disease. There are many neurological manifestations to COVID-19. And these include both acutely during the infection, as far as sequela, which is a fancy word for saying like what are the long-term side effects. So similarly to clots and effect on heart, there's also effect on brain, blood vessels. There are strokes that can occur with patients with COVID-19. Some of them may have seizures. And also, as far as long-term, there have been more and more reports of patients with some cognitive complaints, memory problems, and decreased cognitive function. And I think it's important to realize that that the best way to prevent all these serious side effects, which occur in a significant amount of patients. And I've personally seen, and it's really sad, I've seen pregnant women in their early 30s, comatose with seizures and bleeds in the brain. And the best way to prevent that is to get vaccinated. So I think the primary message that we have in this webinar is the best thing to do is to get the vaccine, which helps prevent COVID-19 in a large number of patients. And even in the case of the variants, you'll still avoid the most severe forms of the disease. So I think that that's important to reiterate. We're really trying to prevent tragedies. Neurological symptoms are very common in patients with COVID-19.
Excellent. Excellent. So I think we have also Dr. Jason Cormier on the call. Jason, are you with us on this call? Can you hear us? And I think he's a neurosurgeon and president of SBMT. We will go to Dr. Vicky Yamamoto. Dr. Yamamoto, you had a great presentation for a congressional briefing. So can you update us about the latest, and if you have any slides you can share with us?
Yes, I do. Actually, let me screen share. Just a minute, please.
Dr. Yamamoto is the Executive Director for Society for Brain Mapping and Therapeutics, member of our board, and also a cancer scientist at Norris Cancer Center. So, can you share your screen?
That's on my screen right now.
Okay. Okay. While we are waiting for you, we could have Dr. Chris Wheeler is also immunologist and was associate professor of neurosurgery with me at Cedars for many years. Dr. Wheeler, your thoughts on the vaccination, and just give us a little bit of detail about kind of vaccine therapy. So after Dr. Yamamoto finished with her slide, okay? Vicky, go ahead, please.
can see my screen right now? Is it okay?
Mhm.
Okay, great.
Yes.
Yes, yes.
So briefly, in the next about 7 to 10 minutes or so, I'm going to just talk about so what are some of those effects in terms of a mental effect and also neurological effect based on the paper that we actually published last fall, and as well as some of those mental issues affected by those general public due to the COVID pandemic. So this is actually the paper that we just published last fall, like I mentioned, by us in our group here. This is actually the review article, which is publicly available. It's actually free to download from PubMed. So if you're interested in looking at further, please go to PubMed or let us know so we can send you this paper. This is actually the collection of a review article. And some of those latest articles at the time, more than 1,000 articles in total, and then we cited about more than 400 references. So here, just like our clinicians here earlier actually mentioned that we found out at the time. I think people are all think about this disease as a severe pneumonia, but then we actually early on started to actually notice that this is not really simply a lung disease, but then this is also a collection of many different disorders, that's including ARDS or and as well as a cytokine storm, which is uncontrollable immune response in your body, and as well as acute hypercoagulative state and sepsis and many other autonomic dysfunctions. But then in this paper, we actually find out that this mental health issues or illness are actually the most important side effect of this pandemic. And that really requires a national plan for prevention, diagnosis, and treatment. And that's because when you see a lot of now published data, about 1 in 3 to 1 in 5 COVID-19 recovered patient will eventually have experienced some sort of adverse mental health consequences that lasted for anywhere between a few weeks to about a few months, in some cases maybe more than 3 months. That's including feeling anxiety, depression, PTSD, some sleeping disorder, the brain fog, and so forth. And then at the time, we didn't know much about what could be the main cause, but the very recent study, which was published all this year in the past 1 or 2 months, it turns out that especially the patient with the severe coronavirus patients, what happens is that it appears that this COVID-19 virus can indeed embed into the brain. So in the top picture, for instance, this is actually the case studies published by NIH and as well as University of USC. It's actually the military medical school. This is actually published in one of our members at for Society for Brain Mapping, Dr. Daniel Poor. So this shows that some of those viruses may actually can cause a microvascular injury in the brain from a patient who actually died from severe COVID-19. And then there's another evidence actually shows in case of a post-mortem COVID-19 patient is that you see the evidence that the virus actually can enter and embed inside the brain. As you can see, those spikes of the brain, spikes of the virus can actually seen in some of those patients who died from a severe COVID-19 case. So in all, take-home message from this part is that there are more and more reasons not to get infected with the COVID-19. And especially now, we all know that treating the severe hospitalized patient successfully requires multidisciplinary teams. And especially when someone who may show some of those neurological symptoms, we really need to have a professional neurologist and neurosurgeon consult for those patients in a clinic or hospital. And then we also need to take care of those long haul COVID symptoms. For those who needed some help, we really need to provide some necessary treatment and support. And again, I think we mentioned in the paper that there's there should be a national plan for prevention, diagnosis, and treatment. And I'm pretty sure that now the current administration is doing a good job in trying to establish this national plan for this COVID. But I also would like to mention that this neurological disorders or mental health issue is actually pretty common for those general population, regardless of those who are afflicted with the COVID-19 or not. Because, of course, because of this coronavirus pandemic, we are all under major stress. That's including we have to worry about getting this disorder, but at the same time, we also may have lost some of those loved ones due to coronavirus. And some of us may lost a job, or there's a lot of uncertainty. So mental health issues can lead, can also not only stay as a mental health issue, but the mental health issue, if you do not treat properly, it can actually worsening of health, physical health condition as well, because those people who are under stress tend to, let's say, drink more alcohol, or take some medication or drugs, or start to harm themselves or harm others through violence, and then they think about also about suicide as well. So, but then so as a scientist or researchers and clinicians, we still need some a better way to diagnose those mental health issues, because at this point, most of the mental health issues are diagnosed through self-reported symptoms, which is subjective, which is also very important too. But we are trying to figure out, is there a better way to objectively diagnose those mental health issues? And actually, we just, in the previous talk, we actually discussed a little bit more detail. I'm pretty sure that our panel will discuss in the morning further about this recent advancement in diagnosis method. But as a scientist and clinical investigators are all now trying to figure out if we can utilize some of those brain imaging to assess the mental health issues. And as well as we are trying to figure out if there was any better good health, sort of like a health checkup or health screening. We should have some sort of a brain health screening. So we are still trying to figure out if there's any way better figure out how to assess those mental health issues. So take-home message part 2 is that mental health issue is pretty common during this pandemic, unfortunately, and then we need to address this importance of how to identify and how to cope with this mental health issues. And again, for researchers and clinicians, we still, it's really important that we are going to continue to develop a better way to diagnose and treat mental health issues. So I was wondering, so Dr. Kateb, should I also talk about the vaccination or?
Let's basically have Dr. Wheeler give us some thoughts about overall vaccination. We'll come back to it. I have a short video to show, and then Dr. Wheeler, your thoughts on overall vaccine and why vaccines of today are more safe than before, because obviously some people have hesitation to take shots of these COVID-19 and overall vaccination. So can you give us your thoughts? By the way, Dr. Wheeler also was involved with us in developing vaccine for brain cancer. So we're in phase 3 clinical trial. So Dr. Wheeler, please go ahead.
Sure. Yeah, so let me just start at the beginning and say that vaccines are all meant to do the same thing, and that's to boost your natural, well, not natural, but boost your immune response to a particular disease. That's true of vaccines for brain cancer, as it is for vaccines against infectious agents, including the virus that causes COVID-19. Now, that said, there are two major types of vaccines. One is called therapeutic, and one is called preventative or preventive. And the biggest difference is preventive vaccines, which represent the vast majority of those against virally caused disease, are intended to prevent the disease before you get it. And they're intended to be, they are to be administered to people who have not or currently do not have the disease that it's targeting. The COVID-19 vaccines are all preventative vaccines. The other type, therapeutic, include things like cancer vaccines. So the best way I could convey this is to say that the immune system is like a massive army, okay? And if you can imagine, you know, there's different players to armies. There's special forces, there's landmines, there's spies, there's a whole bunch of different things. But all of those things work together to get rid of the enemy, whatever the enemy is. Now, preventive vaccines are akin to massively amounting that army at a border before a conflict occurs, okay? And so that, you can imagine that's a lot easier to achieve than mounting the army and mobilizing the army after an invasion or an attack occurs. And that would be the therapeutic vaccine analogy, okay? So I've had people ask me, you know, I know I could still get COVID-19 after I'm vaccinated, so it's not a preventive vaccine. It is, that's the intent. It's not perfectly preventive, it's 95% effective, which is pretty close as far as preventive vaccines go. So it's not a therapeutic, it's a preventive vaccine. Second thing are the components of vaccines these days are quite different from the components of historic vaccines, like polio, like for other infectious diseases throughout history. Initially, the first vaccines were made from the actual disease-causing agents, so viruses, for example, and they were killed or inactivated in various ways and then administered to patients. And at least in a few cases, that led to the patients actually getting disease, not very many people, but in some diseases and in a few patients, they actually got the disease because the inactivation was not efficient. That has been addressed in various ways. First of all, by making that inactivation or killing of the disease-causing agent more efficient, but even more so these days is not using a live virus or the disease-causing agent in its entirety. And so that is the biggest difference between historic vaccines and the vaccines we use today. Now, the COVID-19 vaccines go one step further. They don't even use any real assemblage of the infectious agent. They only use one little piece. In the case of the Pfizer and Moderna vaccines, they use the spike protein, which is the protein that the immune system responds to most vigorously and is most effective at preventing infection. So that spike protein is either encoded by mRNA for Pfizer and Moderna, that's encapsulated by kind of a fat bubble. That's the nanoparticle. And that's administered to the patient. And what that does is it encodes the genetic material for encoding that spike protein so that the cells of our bodies can make that spike protein, and our body sees it as foreign and mounts an immune response to it. Also sees the nanoparticle as foreign and mounts an immune response to that, okay? Now, even though that involves genetic material, it's not gene therapy. I've also heard that raised as a concern. So gene therapy is when you're actually altering our own genetic material. We're only dealing with one gene of this virus, which is foreign to us. It inherently stimulates an immune response. and it doesn't stick around long enough to do anything that gene therapy would. mRNA in particular is made to do its job quickly and degrade in the body very, very rapidly. So it's not sticking around. So it's not going to cause any long-term genetic, anomalies or anything like that. Now, there are other vaccines that actually do use viral shells from a different virus that causes a cold, called adenovirus, to encode that same spike protein. That also involves genetic material, but it's not gene therapy. The genetic material there is DNA, which is a different form of genetic material than RNA, but it also is not intrinsic to our own DNA, so it's seen as foreign, along with all the other proteins that viral vector, as we call it, encodes, and that mounts an immune response to both the virus as well as a spike protein. And so that doesn't stay around long either. Degrades in the body, doesn't incorporate to our own genetic material, and doesn't cause long-term problems. So in terms of differences between problem-causing vaccines, which have occurred in the past, they're quite numerous with respect to the COVID-19 vaccines. These are very fine-tuned vaccines. They are specific to only one protein that causes problems in COVID-19, and there's virtually no issue with long-term side effects from the vaccine itself. Now, that said, remember the immune system is an army, and there's various components to an army. Some are jack of all trade, foot soldiers, and some are, Navy SEAL specialists, special operations. Some are those that lay landmines to prevent a battle. And all those components are activated by these COVID-19 vaccines. Now, some of those components, particularly the jack of all trade foot soldiers, are activated by any vaccine because that's needed to start the later stages of a very effective immune response. Okay, so it's those jack of all trade soldiers, which are also called innate immune cells or innate immune responses. Those are the ones that cause these short-term side effects after vaccination. You'll get a sore arm, might get a redness or swelling, maybe a fever, headache sometimes, but they go away because they don't lead to a longer immune response. They're just a very short-term thing. And at some level, it's a manifestation that your immune system is actually working the way it should in these vaccines. And like I said, these sorts of short-term responses are needed for the longer-term immune responses to be jump-started, basically. And those are the specialists, the Navy SEALs or the special ops players. They're the ones that are highly efficient. They're very specific to just the disease-causing agent, and they're able to eliminate the infection when you see it the next time, if you're exposed, very rapidly and very efficiently. So that's how the immune system works. That's what's going on at kind of the body level. At the population level, we have these viruses are fairly rampant or have been fairly rampant in the community. And that causes concern from a couple different directions. First of all, you don't want to get exposed. You don't want to get infected with any of these COVID-19 causing viruses. The second is the larger the population that's infected, the greater the likelihood that these escape variants are going to arise, and in particular, immune escape variants that can resist weak immunity, probably not a strong vaccine mediated immune response, but weak immunity that might be might happen after a natural infection. And we don't yet know that all of our vaccines are as effective against these new variants that are coming out of the virus as the original ones they were tested against by and large. So that's a concern. And it's kind of presents a race of sorts. And the race is to get enough people vaccinated so we decrease the community spread, the propensity to get infected by exposure in the community, before any of these rare variants, which, you need a certain population size to have a rare variant arise, first of all, and then become prevalent in the community. So that race is very real, and I think it makes getting vaccinated a very high priority in public health and in any nation, in particular the ones that have very high levels of infection. So to me, that really is a compelling argument for vaccinated as many people as possible, as soon as possible. And so I see that as my civic responsibility.
Excellent, excellent. Well, we have Dr. Jason Cormier on the call. Thank you very much, Dr. Willer, for your insight to human immunology and vaccination in general and COVID-19 vaccination. So Dr. Cormier, you are a neurosurgeon and you are in Louisiana. You had a strong surge there and inundated a lot of cases. Any thoughts about overall vaccination and neurological impacts of COVID-19 on your patients?
Yeah, thanks, Babak. Sorry I'm late, but a pleasure to be here for sure. Chris was a great talk or insight on the vaccinations. So I would say here in Louisiana, we did experience really a significant couple of spikes actually, despite changing protocols for entering the hospital, checking temperatures, looking at questionnaires, etc. And you touched on the neurological aspects. As a neurosurgeon, I've seen some pretty incredible things from an anatomical standpoint. I did surgery on a gentleman who underwent a posterior spinal procedure in his neck. It was relatively uneventful. He was fine. He had a history of diabetes and he was in his early 60s. So still close to middle age, essentially. And he returned with his cervical wound leaking. And initially it was thought, well, he's a diabetic. There's an increased risk for those sorts of things. The lymphatics don't really run in the posterior aspect of the cervical spine as they do anteriorly. So you do expect some infections, particularly in the diabetic demographic. When I got in there, and as he was admitted to the hospital, he had a positive COVID-19 test. So obviously, we started thinking, well, maybe that's contributing to his infection. And when I entered his neck, his bone was something I've never seen before, and I've performed that procedure. I can tell you thousands of times. It's just my practice is very, very busy. And so the bone was basically, it was fossilized. It was very weird. It had caverns in it that I'd never seen. And this was more of a laminoplasty construct. And so the whole premise of a laminoplasty is to place little brackets at each area between the lamina and the lateral mass of each vertebrae so that you preserve motion in the spine while providing space for the spinal cord to function and to allow the nervous system to function in the lower extremities. So after taking this instrumentation out, just a very, very weird, very strange looking dysmorphic bone. And they really didn't have, I expected to see liquid exudate. I didn't see that. The leaking was more serious, but the bone was, like I said, had caverns that I'd really never experienced or seen before. So that was removed. Of course, the instrumentation was removed. It was washed out. And still, today, like I said, it's very, very puzzling. So that's, I guess, one neurological aspect, just from a neurosurgeon. We have seen, I know you guys touched on the hypercoagulability, those coagulability issues, and we have seen strokes in patients presenting, younger patients, really in their 20s, with strokes that have tested positive to COVID-19. So, you know, and listening to Chris, your insight on the vaccines, I think, yeah, it becomes very important, particularly in this climate where we have a number of individuals living longer in their lifetimes. Their immune systems are certainly weaker. Yeah, I will tell you that I have seen some people that work at our surgical hospital that have, after taking the second dose of the Pfizer vaccine, they were down for a few weeks. It really hit them pretty hard. And these are healthy people, and their concern obviously was, you know, will I get better? They, you know, see other things on the internet. Well, some people have experienced Guillain-Barré, and certainly that's a concern. But not just with COVID, it's also RNA vaccine. It's a concern with the flu vaccine as well. So those things don't, in my opinion, tip the scale not to take that vaccine. But they're very good insight. And yeah, that's kind of a snapshot from Louisiana, if you will.
Excellent, excellent. Well, Dr. Yamamoto, you had some slides to share on the vaccine side. You want to quickly do that, and then we'll go to questions.
Yes, I was told that majority of attendees are all students, so I just made some simple slides for, especially for those who are very young. Okay.
We can hear you well, so. Okay. Can you share your slides?
Yes, that's what I'm doing right now. I cannot see. Hold on. Okay.
So while we're doing that, you know, let's see. Okay, go ahead.
Oh, there's only a few slides, so.
Go ahead, please.
I cannot seem like I can move. Okay, great. So, so especially for those who are young students, I just want to tell you, this is actually my view, but why is COVID-19 vaccination is very important. So there are three major reasons I can think of this. So one is that, although if you are young, especially when you're teens, 20s, and 30s, the risk of death is pretty low. But then even young and healthy are really not completely risk-free. So as you can see, even with people who are 18 to 29 to 30 to 29, once you get it with some symptomatic COVID-19 disease, then you have a 0.5% of a chance of dying for teens to 20s. And when you are 30s, there's a chance of 1.3% who are actually dying from this infection. So actually, the percentage-wise, this is actually much higher than winning $1 million in a lottery tickets. So that's why it's really important that to make sure that you are not going to get this infection even when you're young. And also, there's another thing is that when you have some mild symptom to moderate symptom, many actually patients who recover from this infection may actually have a long, what we call the long haul COVID-19 symptoms. That's including coughing to insomnia to fatigue and then so forth. And that can last for at least anywhere between 3 to 5 months or so. So, and also for, especially for youngsters, actually alopecia or losing a hair while brushing after this symptomatic COVID infection is also problematic, and it can also last for at least 3 months or so. So that's something that we don't want to have. And also, there are some of my actually students also ask that, you know, oh, I just go out only with my classmates who are also young, and then, yeah. Yes, maybe you may probably just only interact with young people, but then what about your friends? They may probably, after the school, they may probably go to do some volunteers or work at the environment. or hospital, for instance, or nursing home, for instance, they may probably working as a volunteer or working professionally where the at-risk populations are actually there. So there is a major actually risk of tertiary transmission. So it's really important to get vaccine, even if the vaccination may cause some side effect, because we really wish to everyone to reduce the risk of dying and as well as reduce the risk of having this annoying long haul symptom, and also to reduce the risk to unintentionally transmit the COVID-19 infection to the high-risk population. So those are very important reasons why I suggest that everyone, if possible, try to get vaccinated. And as a recent actually study shows that vaccine may not actually prevent the infection, just like Dr. Wheeler mentioned, but then it can actually substantially decrease the chance of having severe symptoms and moderate symptoms. And then even I think the current studies involving Moderna and the Pfizer vaccine study shows that those vaccinated individuals can prevent the death at least. So it's really important that if possible, try to get vaccinated. And it's really worth it.
Excellent. Excellent. So thank you very much. So I think we're going to stop here and take some questions now that we have covered the basis for signs and symptoms and vaccination issues. Any chance that we could respond here?
Okay, there's a couple of questions. One of them from a person says, I have 2 small children, ages 2 and 4. Any idea when we might expect a vaccine for them? Without having them vaccinated, I still hesitate to have them out and about.
So in terms of small children's, Dr. Elsayegh, have you seen really significant risk toward very small children among the patient population?
Honestly, to answer that question, there's 2 issues. Number one is, although they've shown some very minor or very rare infections in kids that age, it is unbelievably rare, not common at all. I am an adult physician, so I do not see children. However, from the research that I've done, it's rare that the children at that age are affected or affected significantly to cause severe symptoms. At the same time, I also understand, and possibly Dr. Wheeler may have a better answer, but I do understand that all of the companies, including Pfizer, are currently testing the vaccine in children. Now, I do not know how young the age is that they're testing. However, we're hoping that soon, they're already, I believe, in phase 3 trials, so soon we should have answers or a vaccine made for children. Again, 2 years old seems very young, so I'm not really sure how young they're testing. Right now, between the studies that are going on and the fact that a severe infection is rare in kids that age, I think those are both good signs.
So, Dr. Wheeler, anything to add?
I agree with Dr. Elsayegh. I don't think it's a priority right now to generate vaccines against that age group, against pediatric patients, but it is on people's radars. It is on industry's radar for the coming months. I think the immediate priority is to get adults vaccinated, and as many of them as possible, as soon as possible right now. But I have heard comments from industry players that the next phase is to vaccinate kids. It's just
So
not.
one thing, yes. So one thing that I've come across several papers showing that the ACE2 receptor is basically more expressed in adults. So the ACE2 receptor is basically lock and key for the cell to get into the virus to get into cell. So I think one of the reasons that children are less impacted by this virus is because of that. So, and I share the panel's view that we shouldn't be too worried about that population of children. So,
Dr. Kateb,
how about the next question? Go ahead,
Next
please.
question. Is there any
Dr.
evidence
Elsayegh,
of
did you want to-
subgroups with?
Oh, that's
Dr.
okay. We can go to the
Elsayegh,
next.
did you have any comment?
Well, no, I mean,
Okay,
I
go
wanted
ahead.
to comment on a broader topic related to both children and adults. Is this was mentioned earlier, a little bit briefly mentioned earlier, is that the goal of this vaccine is not to protect one person or the person getting the vaccine. The goal of this is to eventually form herd immunity against this virus. So, the key to this is to vaccinate as many people as possible in the population. So it's not necessary that we have to vaccinate every child. We have to vaccinate 80 to 85% of the population in order to form herd immunity and protect everyone. And that is, crucial to understand in a slide that Dr. Yamamoto had put up, where the vast majority of deaths are occurring in the very elderly. However, the vast majority of cases and of transmissions are occurring in the young, in the 18 to 40 to 18 to 50-year-old population. If you add that up, that's the vast majority of transmission, that's the vast majority of cases. So, the sooner, in my opinion, that we vaccinate that age group, the better it will be for society. Right now, we're vaccinating the elderly because it's helping protect them and helping hopefully protect them from dying. However, the goal here is to vaccinate as many people as possible, and that way we protect both. Sorry, my lights went out here. To protect both adults as well as children by forming herd immunity, and we will not have to worry about specifically vaccinating the 2-year-olds or the 3-year-olds or the 4-year-olds.
Great, thanks for your point. Go ahead, I'm sorry, next question.
Okay. Is there any evidence of subgroups within the population as a whole from whom vaccination might be contraindicated due to underlying health issues, autoimmunological problems?
I'm not sure if Dr. Khorsandi is still on the call with us, but Dr. Khorsandi, if you have any thoughts on this, or Dr. Don Eliashiv, you could have your thoughts. Do you want to repeat the question? Can you repeat the question for our colleague?
Is there any evidence of subgroups within the population as a whole for whom vaccination might be contraindicated due to underlying health issues, autoimmunological problems?
Okay, so Dr. Eliashiv, any thoughts on that, or maybe Dr. Cormier? All right, well, any of the panelists, go ahead.
I think the main contraindication is if you're allergic to any component of the vaccine. And so it's possible you're allergic to components of the adenoviral vector vaccines, because those have been around a little more. The mRNA vaccines, the only thing that we have any experience with allergies, allergic reactions in those vaccines would be the fat bubbles, the nanoparticle fat coverings. I don't know if there are that many people who know that they're allergic to those components, but if they do, and if they have a response, if they are, and they have a response to the first vaccine, that would be contraindicated for the second vaccine for sure. As far as autoimmunity goes, I don't know. I can't think of any specific reason why people with the common autoimmune disorders would not be recommended to be vaccinated. There could always be some cryptic cross-reactivity that makes things worse, but we just don't have much experience there. But those things are very rare.
Any other thoughts on the panel?
Yeah, so first, as Dr. Wheeler mentioned, the main contraindication to this vaccine is if you have if you're allergic to any component of any of the vaccines. And then again, it has not been recommended yet for pregnant women or for children. Other than that, we really tell everyone to take the vaccine. Now, if you're immunosuppressed or immunocompromised with the diseases that are mentioned, or you're taking medications that make you more immunocompromised or immunosuppressed, you can still take the vaccine. Now, you may not be able to mount as strong an immune response as someone who is healthier or is not immunosuppressed, but the recommendation is still to take the vaccine.
Okay, great. So I think if you look at how vaccines are developed, they're enveloped in polyethylene glycol, at least with the Pfizer vaccine. As I said initially, you can't really inject mRNA to body directly. So you have to envelope it into basically a nanoparticle. So that PEG could sometimes give an immune response, but that's really minor. So I think overall the hypersensitivity for this vaccine has been very low, and but I also wanted to take the opinion from Dr. Khorsandi, because he sees a lot of patients at Cedars. So what are the contraindications of the vaccine? They're asking, do you see any reactions in the patients who are immune compromised? Any kind of side effects for cardiovascular issues? Any thoughts on that?
Yeah, surprisingly,
secondary vaccine.
I think both mRNA vaccines with which we have experience with have been surprisingly very, very safe. And just like you said, unless somebody has an allergic reaction, has a hypersensitivity reaction, which also tends to be rare, we really have not. It's been surprisingly clean vaccine, especially if you compare it to the historical vaccines, to other vaccines. It's been very mild. Some people get a reaction as they're supposed to, just like any vaccines. They get a little very slight temperature, they may feel a little fatigued the day after, but that means you're mounting an immune response. I think people who've had COVID before, especially if they've had it in less than 6 months, when they get the vaccine, they tend to actually have more of an immune response. So they may feel more fatigued for a couple of days, but something they take Tylenol or Advil for. But for the most part, it's been very refreshingly clean and safe. And I think it should not stop anybody from, those concerns should not stop anybody from using it, because now it is safe to say probably worldwide with the 2 mRNA vaccines, nearly 100 million people have been vaccinated. And those are staggering numbers, and with which we have not seen any systematic issues. It makes a huge difference. And I think the issue came up because they say it's a new vaccine, new method of vaccine, versus the more traditional ones, which are either attenuated virus or the vector, the DNA vector. Actually, I think it makes it safe that's the mRNA, because just as you said at the beginning of your of this conversation, Babak, the mRNA is very unstable. What is injected gets away from the body very, very fast. They actually have to protect it in that lipid envelope so it can do the trick. To me, it's very clever, and theoretically, the production of it makes it a lot safer than what we've done in the past. And in reality, now that we've been doing it besides the research time in the last 3-4 months, we also see the same reality, which I think is a very nice, pleasant surprise.
Excellent. Yeah, I mean, this is a big difference between the Chinese vaccine and the Russian vaccine, which are, as you mentioned, the weakened viruses. But this one is really, a sequence of spike protein and enveloped in lipid. And I think this is make it very, very effective. So how about the next question? Do you have any other questions?
Here's another one. Are these preventative vaccines safe for people who are taking blood thinners?
If I could ask that.
Okay.
If I could answer that.
Yeah, go
The
ahead.
questions that are taking blood thinners?
Yeah, this question comes up in my practice all the time because a lot of cardiology patients are on a variety of blood thinners. The vaccine is subcutaneous, and it's not, the short answer is yes. There's no concern with it at all. And the only question is, can you put a needle, a small needle, in somebody who's on blood thinners? And the answer is yes. So I would not be concerned.
That includes my own mother, who was on dialysis, and she got it, and she's on blood thinner, and she's your patient, so you saved her life. Thank you. So, yeah, so next question. You have any other questions?
There's several.
Okay, so while you're preparing those, that you can send it, tell it to us. Dr. Cormier, in terms of kind of vaccination in Louisiana and vaccination acceptance, what's your thoughts? Some ethnicities, they're pro-vaccine, some of them are not. My own background, I'm Iranian American, so Persians kind of split like 40%, 30, 70, something like that, getting vaccinated, some don't. So I wanted to kind of very quickly bring up this vaccine acceptance across different group and populations in different part of the country. Your thoughts on what you're seeing from vaccination standpoint. I mean, do people accept that in Louisiana?
Sure. So I think that it was actually a great, well accepted. I think that one of the concerns, however, that I guess sort of stymied the progression of getting or obtaining those vaccination shots is when the talk of pregnant women or the risk of infertility and all those sorts of things came about. I guess in the South, maybe, I don't know, people tend to listen more to some of the negative aspects of something, and they don't actually read into it. They just kind of, listen to what the latest news or jargon is on the street. Another concern was asthma, the asthmatics, and kind of as it was, outlined earlier, if you're not allergic to particular components of those vaccines, then it's relatively safe. So overall, it started off a number of people, almost everyone and anyone was getting it. And then there was a slight bump and some resistance, but people are back, I think, online and taking it. And the numbers have dropped significantly.
Excellent. Yeah, my own father is 88-year-old and he has asthma and he got it. And, he had no symptoms after vaccination. So some people get a headache and nausea, and some people, get fever and chills, but that usually goes away about 24 hours. Okay, Nali, any other questions?
Yes, is there a possibility that the vaccine could be an annual thing like the flu shot?
All right, well, let's see. Any of the panelists will like to pick this up?
I don't know. We
Dr.
don't know. I mean, I'll let the people. I'm a neurologist, so I'll qualify that. I think there are ongoing studies about the effectiveness of the vaccine and how long it lasts. And you're talking about a period like about 6 months. So it really depends. It's an open question, but I do know that Pfizer, Moderna, and all vaccine makers are monitoring the changes in the spike protein as far as the variants, and they're trying to come up with a distinct policy whether they need to update their vaccine. A common example of a vaccine that's updated is the flu vaccine. So how often we will need to change the vaccine or update the vaccine, we don't know. But I still think that doesn't change the message of continuing to get vaccinated.
Excellent.
I agree with Dr. Eliashiv. To me, it comes down to a question of the variants and how prevalent they become. Of course, there's some question of whether the immune responses that are stimulated by the vaccines wane. And they will wane to some extent, but you will always have a level of immunity to what you were vaccinated against for probably a decade or more for the vast majority of vaccines. So that's less of a problem, a concern for me as the emergence of immune-resistant variants. So as I mentioned earlier, vaccines are exquisitely specific to whatever you put in the vaccine. So you will only be immune to what's in the vaccine effectively. That's the only guarantee. The viruses, like the flu, can evolve very quickly. We don't know yet how quickly the virus that causes COVID-19 evolves. And we don't yet have the massive numbers of infections as we do with flu that allows the emergence of these immune variants year after year after year, and that requires yearly vaccine efforts. As I said, we're in a race to prevent that from happening. So the way we slow down that race and get on the winning team is to get more people vaccinated as soon as we can. It has yet to be seen whether we're going to win and whether we will have these variants emerging year after year after year, just like the flu, but I hope not. And right now is our opportunity to
and I think another good point here is that to be made is that unlike HIV/AIDS, COVID-19 does not integrate its genome to human genome. Okay, so that's a big difference. So because of that, overall, how long this virus is going to stay to everyone's guess, but if we can actually mask and physical distancing for now, get everybody vaccinated, I think the spread of this will go down, and therefore the variants will have the less ability to survive, therefore reduce the possibility of second and the third round vaccination. So how about the next question?
Here, I have a family member who is reluctant to get the vaccine. Not to get political, but they watch a lot of Fox News. Can you recommend resources that explains the vaccine clearly, simply, and effectively? They don't want to hear it from me. How do you reach that audience?
Sure. Okay, well, let's see. Who do we pick up here? Anybody from the panel would like to pick up? Let's start with Dr. Cormier, please. Your thoughts.
Well, I mean, first off, this thing is going to take intelligent conversation. People that are intelligent, that you respect, have a conversation with them. It's most likely that they have taken the vaccine because it makes sense. You know, there's going to be a lot of things on the internet, of course. We're not asking you to go to scholarly articles that are going to, you're trying to read in some of these words, you know, some of us can't really comprehend, but the gist of it is that look at the numbers and look at, now some of the numbers are dropping, a lot of numbers are dropping, excuse me, because of the vaccines being taken by a number of people. So we're approaching herd immunity. So that's one thing I would do. You know, there are just intelligent conversation, and you know, go to your doctors. You know, your doctors are smart people. Obviously, those are the people you also trust. And I would hope that they would have some intelligent things to say about it, and to be able to explain to you the differences in those different types of vaccines.
Dr. Elsayegh, how about you? How do you deal with different ethnicities, different political background at Cedars? Or maybe Dr. Khorsandi could also let us know, so we get all types of patients.
This is a tough question, and there's no point in insulting anyone or insulting their intelligence, but I am not 100% sure, and it's unfortunate how this vaccine and this disease has become so political. There is no political debate about having the smallpox vaccine, having, the shingles vaccine, having the varicella, the chickenpox vaccine. I really don't see any senators or congressmen or presidents debating those issues. So I'm not really sure when or why this has become such a political debate. And, it's unfortunate that most people decide to take the vaccine or not take the vaccine, not based on any medical evidence, but based on politicians and whether it's congressional, senatorial, or presidential politicians. My recommendation and my advice is exactly what Dr. Cormier said, which is this is a medical problem. It has absolutely no politics in it whatsoever. So if you have a question, ask your physician. If you have a question about some amendment in the Constitution that you want to discuss, ask a politician. If you have a question about a medical issue, ask your physician. That's what I think.
I think most of us are in agreement here, and I think the other thing that I wanted to bring up, people say, "Well, I'm vaccinated. I'm not going to put masks on, so I'm vaccinated. Why should I put a mask on?" So I think one of the reasons that you put your mask on, that there are studies being done to see if with vaccination, do you still carry the virus and give it to others? Of course, you have been protected with vaccines, but for the sake of others, I usually say that it's, for now, not for, foreseeable future, for now, after everybody is vaccinated, it's better to have the mask on for the sake of, helping others and, other Americans, and for our own patriotic duties. So we allow 2 more questions before we finalize this panel. So please go ahead if you have questions.
Here's another one. Should IVF patients be allowed to take the COVID-19 vaccine?
I'm sorry, can you repeat that?
Should IVF patients be allowed to take the COVID-19 vaccine?
Well, IVF.
Mm-hmm.
IVF.
Yeah.
Mm-hmm. That's a good question. Well, I don't know. IVF patients. I mean, you're talking. They're talking about people who are trying to get pregnant.
Patients that are going through fertilization. Yeah, patients that are going through fertilization, trying to have a baby. I don't know. Unless someone else can answer this, my recommendation is to ask your infertility specialist.
So I think there was a paper published showing that pregnant women pass their immunity to their children. So I think that might be safe to take, but again, as Dr. Elsayegh said, you need to talk to your infertility physician. But there were evidence of basically transferring immunity to newborn. Next question.
Next one. Okay, so here it is. For how long will the vaccination be effective? How effective is it against variants? And if a third shot is needed against variants, how soon will they be available?
So
let me just answer part of that, because that kind of piggybacks the earlier question of how long it's going to last. And, you know, the vaccine, I think people need to remember, that's not the only component of winning this. We still have to be global, from a global standpoint, a cleaner society. You know, still wearing a mask, social distancing, not drinking after each other, and just being a cleaner society is going to help keep the variants away. You can't just take the vaccine and engage in just very dangerous activity, not wearing a mask and drinking after others, and just doing the things that essentially, my opinion, was part of what got us here. So I think it's a multi-faceted approach. I think the vaccine plays one important part of it. The other part is a behavioral, from a behavioral standpoint. And you know, that the paper that was published in September of last year about some of these issues. Think about the cognitive effects and all those things. So all that, it's not just the vaccine. Just remember that the way that we're going to win this and beat this is that understand we weren't a very clean society. This is an opportunity to take a stance, not just with the vaccine, but also being clean, being cleaner, washing your hands. We should all wash our hands, wearing a mask and social distancing them, you know, appropriately.
Yes, and also I think be more cognizant of our kind of brain-body behavior, I would say. So, you know, we have many Americans who deal with obesity. So I think exercise, diet properly, and kind of you know, have a fit mind in terms of disciplining your diet and exercise to be able to get away from some of the diseases that could put you right at the center of this type of you know, pandemics. We can, you know, see across the board, many of our patients who died, they had underlying conditions, and, you know, many of those underlying conditions could be managed. So really our message to the audience is that we've got to, you know, set our body, you know, kind of eat healthy, exercise, live healthy, and by doing that, you will boost your immune system. So, okay, in closing, I wanted to go around and, of course, thank you all of the panelists and our organizer, Professor President Mary Gallagher, for providing us this opportunity to educate about 250,000 staff, student, and faculties of LA City College, Community Colleges District. So wanted to go quickly across the panel and see if we missed anything, your final thoughts. Maybe we can start from Dr. Willer first on the immunology. Any final thoughts, anything we missed in this conversation?
Nothing particular that we missed in the conversation. I think what we're missing now is just more extensive data on the vaccines themselves, their efficacy against these variants. There is some published and pre-published information out there, but it's mixed. You know, the UK variant seems to be effectively dealt with the Pfizer vaccine. The South African variant doesn't seem to be by the AstraZeneca vaccine, but it's just, you know, bits and pieces like this. So I think we're waiting for more information, and, you know, we could make better personal and policy decisions based on what comes at that point. But for now, the take-home message for me is just get vaccinated whenever and as fast as you can.
Excellent. Dr. Elsayegh, your final thoughts?
Yeah, I mean, this is a talk about vaccination. So obviously my recommendation as a physician is to get vaccinated, and the more people we vaccinate, the better it will be for the community, for the United States, and for the world. You know, the big question is always, which vaccine should I take? And again, I want to emphasize that the point of this vaccination strategy is to form herd immunity, meaning that if one vaccine is 95% protective, the other one is 85%, and one is 92%, whatever that number is, it's irrelevant when you're trying to form herd immunity. So my recommendation is, whichever vaccine is available to you, please take it. There is not one better than the other, especially not when you're trying to form herd immunity.
Excellent. Dr. Cormier, your thoughts?
Yeah, I would just say, you know, I really enjoyed it. Really good insight from all the panelists and good questions that came in. I would like to just say that, you know, there are still a number of people that think that this is a big joke, that it's not real. And I will tell you, do not wait. Don't wait until it hits you or hits your family, because the people that have had it, they go down hard, and people do expire. They do pass away. So don't wait until it hits your family member. Do the safe thing. Be smart. This is real.
Yeah, indeed. I had a couple of friends who, well, distant friends, who thought, were not physicians, just, but they thought that, okay, well, you know, I will hang out with friends, I'll be careful, and they end up giving it to their parents, and unfortunately, we had several bad news, you know, about them dying. So it's sometimes less is about you, more about others. So I think that's very important. Dr. Yamamoto, your thoughts, final thoughts?
Yes, here. Yeah, my final thoughts, again, you know, I advise everyone, as in my presentation, is that if possible, please vaccinate it. This is probably the only way to fasten our recovery to get back to normal. So we are all in this together.
Great, great. Dr. Don Eliashiv? I don't know if Dr. Eliashiv is still on the call, but maybe not. Or Dr. Khorsandi, are you still on the call with us? Any thoughts, last minute thoughts that you have to share with us? You could. You know, I think one of the questions that I saw was about are the schools are safe to open? So I think that proper masking and you know, proper you know, protocols, which are already been sent by the CDC to universities and colleges, it is safe to open the colleges, and that's not a political stand. That's not a, you know, scientifically speaking. I think at this stage, we at least recommend that all the you know, faculties and staff get their vaccination, go back to work, and I think hopefully by fall the universities will open up, and we could have a very productive educational training. So I don't know if Dr. Mehran Khorsandi has any final thoughts, or maybe he's in the clinic, but Dr. Gallagher, you know, I'm going to just share my last slides with you here, and basically kind of you know, mention that based on our conversation today, we are all in agreement that COVID-19 is not a flu, so thyroid typo. Wear a mask, wash your hands, and get your vaccine. All vaccines are effective. And we have a video about 7 minutes that you can post it for your students to show that basically, you know, if you're looking at vaccines, Johnson & Johnson, Pfizer, and or Moderna, then you're talking about 94% to 70% efficacy. You're talking about basically, looking at a percentage of people within a clinical trial, okay, not being infected or being infected. So what does that mean? That means that the clinical trial that Pfizer started at the beginning, Pfizer and Moderna, beginning the spike of the United States. The clinical trial that started by Johnson & Johnson was basically at the time of the peak. So the people that they vaccinated, mostly on Pfizer and Moderna, did not get COVID-19. And basically, people that are vaccinated by Johnson & Johnson, at that time, the variant of South Africa was in play, and some people get more, infection. Now, having said that, 70% or 95% or 80%, it's enough for you to not have a significant symptoms and or be hospitalized and God forbid, die. So that's enough for anybody to get their vaccinations. And also, if you compare that with the flu vaccine efficacy is about 50 to 60%. So with flu vaccine, you could really get away from flu. So this one, almost all vaccinations are over 80%. So with that, I turn the floor to Dr. Gallagher. And as I said, the panel's recommendation that everybody should get vaccinated, protect yourself until you are vaccinated, and follow the guidelines by university and school district to get back to school, get back to work, get back to learning. Dr. Gallagher.
Yes. Thank you so much, Dr. Kateb, and thank you so much to all of the experts here today who shared your knowledge, your information, and the great wisdom of what we need to do in our communities to stay safe. And I greatly appreciate it. We will be distributing this very widely. We did record this and we'll be distributing it widely. And Dr. Kateb, I'll get the additional information from you and send it out to the campus. So thank you again for your time this afternoon. I greatly appreciate it. Hopefully we'll see a lot of our community now vaccinated as a result of hearing from all of you. So thank you again and have a great rest of your afternoon.
Thank you very much, Dr. Gallagher. Thank you very much, our panelists and our attendees. Have a good day. Bye-bye.
Greatly appreciate it.
Thank you.
Thank you.